In this section, we will discuss some basic anatomic features of the popliteal fossa. As with any nerve block, a correct understanding of anatomy is the best way to achieve a safe and effective result. The block techniques we describe are based on sound anatomic principles. There are many techniques that work, and we stress that our methods represent only a sample of these. Finally, as you move through the images displayed here, be mindful of the medial and lateral orientation of the image. We present various image orientations here in order to improve the experience of the viewer. The popliteal fossa is a diamond-shaped space. The superior border is defined medially by the semimembranosus, semitendinosus muscles and laterally by the long and short heads of the biceps femoris muscles. Inferiorly, the borders of the space are the medial and lateral gastroc muscles. Within the popliteal fossa, the spatial relations of the popliteal artery, vein, and components of the sciatic nerve change between the popliteal crease and the apex of the popliteal fossa. For example, at the level of the popliteal crease, the popliteal vein is superficial to the popliteal artery. The tibial nerve is, in turn, superficial to the popliteal vein. However, as we image towards the apex of the popliteal fossa, the vein and sciatic nerve assume more superficial and lateral positions relative to the artery. You will also note at the level of the popliteal crease that the tibial and peroneal nerves are separate, with the peroneal nerve being considerably more lateral than the tibial nerve. Next, we will see fresh cadaver dissections of the popliteal fossa. In this fresh cadaver dissection of the popliteal fossa, we see the semimembranosus, semitendinosus muscles medially and the biceps femoris muscles laterally. The popliteal artery and popliteal vein are marked with a vessel loop, and the tibial nerve and peroneal nerve are visible lateral and superficial to the popliteal artery and popliteal vein. There can be considerable variability with respect to the level at which these nerves unite to form the sciatic nerve. The sciatic nerve is also superficial and lateral to the popliteal vessels. There are some helpful steps to follow when imaging the popliteal space. By starting at the popliteal crease, the imaging depth is decreased and some initial landmarks are more easily identified. While applying firm pressure and keeping the transducer motionless, the pulsations of the popliteal artery can be easily recognized. Using the popliteal artery as a point of reference, the popliteal vein and tibial nerve can be more easily recognized. And finally, the nerves within the popliteal fossa exhibit a property called anisotropy. Anisotropy is the quality of exhibiting variable echogenicity when measured along different axes. In the case of the sciatic nerve, tibial nerve, and peroneal nerve, it means that nerves are more echogenic and therefore more visible when the transducer is angled caudad 15 to 30 degrees rather than at an angle perpendicular to the skin. This slide compares the position of the transducer when it is held perpendicular to the leg on the left and when the transducer is angled slightly caudad on the right. This is a diagram of the ultrasound image produced with the transducer at the level of the popliteal crease, as shown in the inset drawing. Note the positions of the popliteal vein and tibial nerve relative to the popliteal artery. The peroneal nerve is considerably more lateral and deep to the biceps femoris muscle. As the transducer is moved to the mid-popliteal level, see the inset diagram, the usual positions of the popliteal artery, vein, tibial nerve, and peroneal nerve are recognized. Namely, the popliteal vein is superficial and lateral to the popliteal artery, and the tibial and peroneal nerves are superficial and lateral to both vascular structures. Note that at the mid-popliteal fossa level, the tibial and peroneal nerve are usually still visible as separate structures. At the apex of the popliteal fossa, the popliteal vein continues to be superficial and lateral to the popliteal artery. Note that this level is proximal to the division of the sciatic nerve into the tibial and peroneal nerve. However, there is considerable variability between patients with respect to how proximal this division occurs. This video illustrates the principle of anisotropy. In these simultaneous recordings of the transducer position and the ultrasound image, note the increased echogenicity of the tibial nerve as the transducer is angled caudad approximately 20 degrees. As the transducer is returned to a position perpendicular to the skin surface, the echogenicity of the nerve is significantly diminished. In this image, we will see structures typically visible during an ultrasound exam of the popliteal fossa. Note the simultaneous display of the transducer position on the right. The exam starts at the popliteal crease where the biceps femoris, semimembranosus, and semitendinosus muscles are visible. They represent the lateral and medial borders of the popliteal fossa, respectively. The popliteal artery is visible as the transducer is pressed firmly against the popliteal crease. This pressure also compresses the popliteal vein, which is immediately superficial to the popliteal artery. Using the popliteal artery as a point of reference, the popliteal vein and tibial nerve can be identified immediately superficial to the popliteal artery. As the transducer is moved proximally on the thigh, the peroneal nerve is visible as it moves from lateral to medial immediately prior to joining the tibial nerve to form the sciatic nerve. In this image of the left leg, there is surface video of the ultrasound transducer on the left and the corresponding ultrasound image on the right. The exam begins at the popliteal crease where the popliteal artery and popliteal vein are readily visible. The popliteal vein can be distinguished from the artery by its superficial position lateral to the artery and with the ease with which it is compressed by the transducer. The tibial nerve and peroneal nerve are also visible in a position superficial and lateral to the popliteal vessels. As the transducer is moved proximally to the apex of the popliteal fossa, the tibial nerve and peroneal nerve come together to form the sciatic nerve, which is visible superficial and lateral to the popliteal vessels. In the next few slides, we will examine how injectate is distributed within the popliteal fossa after percutaneous injection. Specifically, we'll discuss whether there is a sheath surrounding the sciatic nerve and what factors determine how closely the needle must be positioned to the sciatic nerve for successful injection. A careful examination of the popliteal fossa reveals connective tissue throughout this space that is generally oriented in a coronal plane. These fascial planes include, but are not limited to, the investing fascia of the leg muscles, as well as fascia extending between the sciatic nerve and the semimembranosus, semitendinosus muscles. As we will see in the next ultrasound example, these fascial planes can affect distribution of local anesthetic injected into the popliteal fossa. In this image of the left thigh, the transducer has been positioned at the level of the sciatic nerve. In addition to the investing fascia of the thigh, there are fascial layers oriented in a coronal plane that extend between the sciatic nerve and the semimembranosus, semitendinosus muscles. This ultrasound clip illustrates clearly how these fascial planes can affect distribution of local anesthetic. Notice how there is tenting of the fascia as the needle approaches. This diagram shows the needle position and subsequent distribution of methylene blue dye when the injecting needle is positioned 1/2 centimeter medial to the superficial border of the sciatic nerve. In this fresh cadaver image, we see the distribution of methylene blue dye after a 30 ml injection 0.5 centimeters medial to the superficial border of the sciatic nerve, immediately proximal to its division into the tibial and peroneal nerves, as shown in the inset diagram. In this injection, ultrasound was used to position the needle tip deep to the connective tissue between the sciatic nerve and the semimembranosus, semitendinosus muscles. The extensive staining of the tibial, peroneal, and sciatic nerves for a linear segment of approximately 10 centimeters demonstrates that although there are layers of connective tissue oriented in a coronal plane within the popliteal fossa, there is not a sheath preventing spread of injectate between the point of injection and the nerve. Although there is not an obvious sheath surrounding the sciatic nerve and its divisions, there are a number of connective tissue layers oriented in a coronal plane within the popliteal space. This image illustrates that these layers of connective tissue are extensive in some individuals. The presence of connective tissue oriented in a coronal plane within the popliteal fossa may explain suggestions by some authors that the successful sciatic nerve block requires immediate proximity or contact between the injecting needle and the nerve. We prefer not to approach the nerve directly because inadvertent needle contact may cause trauma or be uncomfortable or injurious to the patient. An alternative to this technique, the direct contact approach, is to position the injecting needle medial to the sciatic nerve. When using this technique, it is important to be mindful of the layers of connective tissue oriented in a coronal plane that may affect distribution of local anesthetic. It is also important that the needle tip not be positioned within the investing fascia of the semimembranosus semitendinosus muscle, since the investing fascia will retain the injectate within that muscle and not allow distribution to the nerve. Although these examples show out-of-plane approaches, an in-plane approach is also possible. Here we see the injection within the investing fascia of the semimembranosus semitendinosus muscle contained within that muscle. This is an example of the local anesthetic distribution that results from a 30 ml injection using a fenestrated needle. The pencil point 20 gauge needle is positioned 1/2 centimeter medial to the sciatic nerve. This particular needle has 8 side ports as shown in the adjacent picture. along the distal 2 centimeters of the needle. The outflow pattern for this needle is shown in the left-hand side of the screen. In some cases, it is beneficial to perform the popliteal fossa injection distal to the bifurcation of the sciatic nerve. It has been suggested that the onset of local anesthetic effect is more rapid when injection is performed at the level of the tibial and peroneal nerves. This may result from the smaller calibers of these individual nerves relative to the larger caliber of the sciatic nerve. As with other nerve blocks, the technique of positioning the needle tip in contact with or in immediate proximity to the nerve may result in patient discomfort or injury. An alternative is to advance the fenestrated needle between the nerves to achieve even distribution to both the tibial and the peroneal nerves. In this image, we see the placement of a catheter in the popliteal space. In this image, we see the performance of the block using the fenestrated needle, which has 8 side ports demonstrated in the image on the left. These side ports facilitate local anesthetic distribution throughout the space between the tibial and peroneal nerves, despite the presence of these connective tissue layers oriented in a coronal plane. In this image, we will see the placement of a catheter in the popliteal space using a conventional 18-gauge standard bevel needle. Note that the ultrasound transducer is outside the sterile field. This field is created using a clear fenestrated drape with a circular adhesive border. The thin-walled needle is advanced out of plane and medial to the sciatic nerve. As the needle is advanced, a number of connective tissue planes are visualized. Using hydrodissection, the needle tip is advanced through each subsequent plane until hydrodissection demonstrates a successful spread of local anesthetic around the nerve. The 20-gauge epidural catheter has been preloaded in the hub of the needle if you look on the image on the right. This eliminates the need to disconnect the tubing prior to inserting the catheter. So when injection is complete, the catheter can simply be advanced through the hub of the needle. The catheter is then advanced 5 to 7 centimeters into the tissue plane, which has been expanded with local anesthetic, and the needle is removed. This is another example of a catheter placement in the popliteal fossa. Again, the transducer is outside the sterile field. The white arrows show how the point of the needle insertion can be correlated to the ultrasound image. For example, the white arrow in the ultrasound image shows the anticipated path of the needle on the medial half of the ultrasound image. The needle is likewise advanced out of plane at the medial aspect of the transducer. Unlike the previous example where the catheter was preloaded through a side port at the hub of the needle, this case requires the tubing to be disconnected prior to advancing the catheter. The example displayed in this image is important in that it represents the appearance of the sciatic nerve in individuals with thin muscular legs. The sciatic nerve is closely bordered by the biceps femoris laterally and the semimembranosus, semitendinosus medially. There is little, if any, interstitial tissue. This close approximation of the muscle and fascia provides an opportunity to display the importance of injecting into the correct fascial plane, and likewise the ability to perform successful nerve block without immediate proximity to the nerve. As the needle is advanced out of plane and nearly a centimeter medial to the nerve, hydrodissection is used to identify the fascial plane that is contiguous with the sciatic nerve. At the end of injection, the white arrows display extensive spread of local anesthetic around the nerve without any evidence of a sheath preventing spread of local anesthetic from the point of injection to the nerve. We hope this lecture is helpful in understanding the anatomy of the popliteal fossa and how these principles impact sciatic nerve block. As always, we have presented a few techniques that are effective, but recognize that there are a number of methods that can also be used. Thank you.